Pnawn da, croeso I Ruth, Helen a'r team.
Well, good afternoon. Very warm welcome, everybody.
One in a series of public accountability meetings with all health organisations. I'm being joined by some senior team in the Welsh Government, and you have a representation from your board, Ruth. There's a lot of us in the room, so I suggest that rather than spend the time introducing ourselves, that the first time each of us speaks, we briefly say who we are at that point, and that keep us on track. The meeting is being live streamed for the public, so if we can avoid acronyms and complex terminology so the public have an understanding of what we are sometimes saying in a technical space, that would be helpful. There are translation facilities, felly mae croeso i unrhyw gyfrannu yn y Gymraeg neu'r Saesneg fel y maen nhw, a bydd cyfieithu ar y pryd.
So you're welcome to translate in Welsh or in English, and there'll be simultaneous translation for those joining remotely as well.
In advance, and that's helped us understand some of the answers to some of the questions that we have. So necessarily in these meetings, as a result of that, the areas that we focus on are the areas that we are looking for more assurance. But there is an opportunity at the start of each section for you to set out as a board your view of how things are. So where some of the conversation may end up being about challenges, there's an opportunity there for you to set out some of the positive steps as well. I would say, and I don't mean to be rude, but it would be helpful if that introductory piece could be kept as brief as possible, so that we can use the time that we have together to have an open discussion. And hopefully colleagues won't mind if I interrupt if we're going a little too long. Before we get into the agenda, Ruth, would you like the opportunity of setting the scene from your point of view?
Diolch, Cabinet Secretary, pnawn da, colleagues. Thank you for the opportunity to open the Public Accountability meeting today on behalf of the DHCW board. I'm really pleased to be here as the interim chair of DHCW, which is the national delivery organisation for the NHS in Wales, means we design, build and run systems that clinicians and patients rely on every single day. We deliver a mixture of operations and new programmes, and around 80% of our resources are committed to those operational services. That's an incredibly high proportion of our resources spent on keeping the lights on. And what does that mean? That means ensuring that over 100 operational services used daily by partners are available, stable and secure in an increasingly hostile cyber environment. It also means getting the lights back on when they go off, as they did this morning, where we had a period of outage to the NHS app of an hour. Some people have suggested we may have done that deliberately today, so we have something to discuss with you when it comes to talking about things that go wrong and how we fix them. But I can assure you that that was not the case. Just today alone, our systems will support care for people right across Wales, with over 40,000 professionals logging in to deliver care and keep services moving. Our Welsh immunisation system is running in more than 3,000 sites, with around 4,000 staff using it right now to deliver vaccinations. In GP practices and community pharmacies, more than 14,000 clinicians will use our digital services today, and across secondary care, thousands will depend on our national platforms to deliver safe and effective care. In primary care, we provide the full digital service for GPs. That's hardware and devices to software, data and support. Beyond primary care, we focus on national systems and standards, while health boards remain responsible for their local hardware infrastructure and locally hosted systems. We do not run hospital IT, and that distinction matters. It shapes our accountability and sets the limits of what we control. Our role is to enable, support and connect, not to run the entire digital estate, and clarity on this point is important, and we welcome the ongoing conversations that we're having with Welsh Government colleagues and health boards about making those responsibilities even clearer. Whilst we successfully operate with over 99% of availability, we have experienced significant challenges across some of our major programmes. We've had delays in areas like diagnostics, intensive care systems and elements of the national data resource. Last year's move to level 3 monitoring was welcomed for us because it enabled us to have a spotlight on some of our major collaborative programme delivery, and it helped us further sharpen our scrutiny, strengthen our programme governance and accelerate system-wide alignment, which has been really important for us. We've also taken on board feedback from our independent stakeholder review. Our stakeholders told us that while services are valued nationally, relationships and engagement needed strengthening. As a board, we're working on this, and our focus is, on supporting predictable, transparent and collaborative delivery across all of our projects and programmes. We're shaping a new operating model for DHCW, And we continue to further strengthen programme governance through our programme delivery committee, with strengthened board oversight and closer working relationships with our colleagues in Alex and Nick's teams, who are helping us with wider system governance structures and alignment. There is a lot to get into, so I look forward to that conversation today.
Thank you. As you said, there's a number of things that we come on to discuss in the course of the next 19 minutes together. We're going to cover 4 areas in the agenda. Firstly, how we are improving the public's access to digital services. Secondly, what digital services for health and care more broadly look like. Thirdly, how services are being prepared for the future. And fourthly, how the organisation is being run and how the organisation can be strengthened. The first of those is around improving public access. Some of the questions throughout are informed by correspondence which the public has sent in, so that their interests and concerns are reflected in the discussion that we have. But who would like to open very briefly that section from the board's perspective?
Diolch. I will ask Helen to open up for us.
Diolch, Cabinet Secretary Pnawnda. I'm Helen Thomas. I'm the Chief Executive of Digital Health and Care Wales. I'll start by saying we know that people's experience of digital services shapes their confidence in the NHS. So that's why over the past year we focused on expanding what patients can actually do digitally, especially through the NHS Wales app. More people can now book appointments, order prescriptions and see parts of their medical record. And most recently, we've added the ability for patients to view their referral onto a hospital waiting list. So for anyone referred from December onwards, they can now see their referral has been accepted into secondary care and check their waiting list status, and of course access information to help them manage their health while they wait. Adoption's steadily rising. Every improvement has been achieved through strong collaboration, very strong collaboration with our health board colleagues, with Welsh Government, and importantly with patients themselves. We are very aware of the challenge ahead of us and the need to keep simplifying user journeys and making that experience really seamless for patients. Programmes like Digital Medicines and the Dental Access Portal show that we co-design with users. We create clearer, fairer and more convenient access to care. We also recognise, though, that digital can unintentionally widen inequality. That's why our digital inclusion plan is so important to us as an organisation. It reflects our commitment to making sure every community can benefit from digital services, and that where we can influence it, no one is left behind.
Okay, Helen, thank you for that. Ruth, where I want to start is this. We all want to see a system where there is minimal duplication, where there's no fragmentation, where the services that we offer digitally are connected, they're integrated, they're seamless. DHCW works with other NHS Wales organisations, with social care partners, obviously with suppliers. How are you making sure that fragmentation, that duplication doesn't arise and is minimised? And who do you think I should hold to account when that doesn't happen?
Diolch, thank you. I'm going to ask Ivan to comment on that to start with us. Thank you.
Ruth.
Yeah, thank you very much, Ruth. I'm Ivan Evans. I'm Director of Strategy for DHCW. Now, I think that working, as you've referred to, working on whole system level is challenging. There are different processes and priorities in every organisation. And there is also freedom within the framework of different organisations to make their own decisions about what systems they want to implement. Now, we have seen an increase and progress over the last year and a half. Technical developments and the app that Helen has referred to, it is very possible that they are working together. I think what has driven that change is, first of all, we have placed an emphasis on collaboration with our stakeholders, mainly because of the review that's going ahead. But we've also seen the system response through the new governance system and through the groups. For example, the groups discuss digital regularly, almost every month. And part of that has responded to the diagnostic systems. The diagnostic systems and the emergency systems have come under huge pressure. As we have seen, we have responded to those crises. For example, what we saw during COVID. Now, in some areas, I think we are building on very firm foundations. What we've got in Wales in terms of national systems, well, the app is one, but the nursing records, the diagnostic system, they are all Wales systems. Also the cache for documents and results of tests, and also the clinical portal. The National Clinical Portal is on an always level. So I think that matches the shared care that regions in Wales would be happy with. Having said that, we have got a long way to go, however, and the technology and our work has shown us that there are over 1,400 different systems in operation. It does vary, as you say, across the system, and it is a constant challenge to try and move people from those legacy systems that were established to one system. But we all share the same ambition. We all agree that we need to centralize and share data and move to similar systems or the same systems. However, the challenge meticulous. So when it does come to a question of moving from 10 legacy systems to one system, there are reasons why people want to hold on to their current systems. So we are working with the Welsh Government to ensure that there is clear guidance from Welsh Government and that we can work hand in hand with you. One of the great frustrations is that, well, there are a few examples, in fact, of different projects where things are progressing slower than expected. So the information that we are getting is that milestones are hit late. So I'm interested to hear your opinion about what's behind that. What's behind the delay? I would argue that perhaps there might be not enough collaboration between the systems so that things are dealt with accurately and on time.
Slade to come in on that question.
Yeah, I'm the Secretary. I'm Slade. I'm Director of Primary Care, Mental Health and Early Years, and also having digital policy and delivery. So I suppose a question on confidence. So several major programmes have been delayed, reprofiled, and so I suppose two parts. How confident are you as a board with the current profiles of those major programmes? But actually looking ahead, how do you, in terms of, I suppose, your system leadership role, how do you build that confidence, both with the NHS as a system and Welsh Government and then the public, and avoid that issue around, I suppose, last minute notifications, disappointment, challenge in the system, which really has that impact on the confidence?
Okay, so we're talking about why you think that's happening as well. Well, what's the reason for that?
Yeah, I mean, I think we share your frustration. We share your frustration as a board when things don't happen as quickly as possible, or we get informed what we perceive to be late in the day for things.
Why is that happening, Ruth?
So we've experienced this across some of the major programmes which have been running for quite some time, and I think we'll touch on the structure of that in some of our answers to our questions. But as we move to that more agile working, we are then able to get those updates more quickly. And I think the structure of those programmes has held us back in some of those ways. But I will ask Helen to comment specifically on these major programmes.
Yeah, please do. But I do want to get an answer to the question of, is it the board's view, for example, that the information isn't coming to the board in a timely way, or is it the executive's view that it's being discovered very late, or is it the view that it's discovered and then not communicated? I just want to understand. I mean, it'll vary, but I want to understand what's going on, really, because it's a significant challenge.
Yeah, no, and we acknowledge it and appreciate it. There are many factors to why some of the milestones will be kind of, delayed and then only materialise in terms of a delay at the last minute. Some of that will be around optimism in terms of the plans. And teams, not just our teams kind of, the commercial suppliers and partners that we work with and teams across Wales. And I think some of that is that we acknowledge we need to do more discovery, need to spend more time upfront really understanding exactly all of the complexities involved in particularly in some of the kind of novel implementations that we are working on, and where the data is unknown and where the processes are new, actually, to all of the teams. The other factor, I think, is that these are highly complex systems. We take some of our major implementations at the moment, like the diagnostics programs, multimodal kind of complex systems that are highly critical, and you can't get it wrong. Getting it wrong is has the potential to cause major harm, but also will really, really impact on health service delivery. So trying to line up all of the work that needs to be done, both by DHCW, by our health board colleagues, and by the supplier. We work really hard at that, but sometimes things, happen during testing that mean that things are not where they need to be and they can't go live. There are some things that are external factors in that as well, in terms of other programs and the pressures in the service where things have to shift. That's happened in the RISP program, so the radiology program, talking in acronyms. So where we've seen kind of a bit of shuffling of dates for each of the implementations, and that there have been a variety of reasons, and some of those will be related to readiness of that particular implementation or related to wider factors in terms of the congestion really that there is.
Can I just ask you, I do want you to address Alex's point about confidence in existing answers as well, but just before we come back on that, so I understand that these are complex projects inevitably. I'm looking particularly for assurance on the question of when flags are raised, if I can put it like that. I mean, when flags are raised early on, people can do things about things, and adjustments can be made and expectations can be managed. But when they come very late, that's obviously more challenging, and nobody will think that's acceptable. So, is there something going on which is telling you, as an organisation, actually we need better leading indicators of what's going right or wrong? We need to be faster at airing things when they are challenging. What's your take on that as a team?
I think the programme boards, they discuss these things at length, as you'd expect. But I think that there are, you're trying to get the confidence of a wide range of stakeholders to stick to the plan. And then if something comes up in testing, which is the end of the process, isn't it? And often that, will happen. That's why we test, isn't it? And particularly in these critical infrastructure systems. So when those things happen, we escalate straight away. So as soon as we're aware, I speak kind of very frequently with the chief exec colleagues on any major issues, and we escalate those. And I think they're probably fed up of talking about diagnostic programs with me, because we've been in this journey together. But we've talked about them every month, and now it's every week actually, because we're managing a critical path. But I think there are so many factors in that. But we will, like this morning's issue, I notified Alex straight away. Where there are issues, we are being open and honest in managing that. And I guess it's the challenge being is, and the shift that we've seen in the industry for many years now is to that agile work and is to product operational. We're going to talk about that, perhaps in further questions, because that's in our evidence pack. But that's the reason, because you would want to move to a continuous improvement cycle of these things, where you're doing, shorter implementation features, and they're kind of come in more quickly, rather than the huge amount of change that actually is being developed and implemented, the huge amount of data that needs to be migrated. Actually, there are so many things, there are so many points in that process that actually where either something is not right or confidence is not where it needs to be in the user base. And I think there is a bit of a challenge for us in our current programme structures that will mean that there's almost a default sitting, okay, well, maybe we need more time. And I think that is a collective challenge for us as a system to be really clear about the consequences of that. And that's what we've been managing in the diagnostics programs, I would say.
And do you just find, I do want you to come on to the confidence point as well, but do you see yourselves as, so the question of time, take for example, I think that's a fair point, isn't it? There's a sort of perhaps bias and optimism about how quickly things can be delivered. I think that's quite a widespread challenge, obviously. But do you see yourselves then in a position where you have a system leadership role in bringing people to a more realistic place? Or how do you see your role in solving that challenge, if I can put it in the room terms?
No, definitely in that place. I mean, clearly the risk is being held. We hold risk in terms of the technical infrastructure, but actually the risk of delivery, of course, sits with the Health Board and Trust colleagues. So there's a partnership with that. So I've worked and communicated with chief exec colleagues, actually. We've used that quite effectively, I think, because they understand the criticality and the importance of the programmes of work. So, but if there is a lack of confidence in one health board and that knocks on to another health board, and we may have a different opinion on that, it is quite difficult, Cabinet Secretary, to get to kind of a collective view on that, which is why I've started to kind of have that conversation at the chief exec level.
Should you anticipate a bit of that though? Because that's inherent in the system that we have, really.
Yeah. It happens in every programme.
I think that comes back to the way that the programmes have been set up previously, and one of our biggest learnings has been the fact that more discovery at that outset would help with anticipating some of these challenges going forwards, and it would help with that optimism bias as well. So you would be letting off on sounder footing than perhaps we have done in the past.
Okay. Can I just ask, because I think we've had quite a lot, so thank you. Do you want to come in with a confidence point looking forward from where we are today?
Yeah, so and even though, you know, we'll use diagnostics perhaps as an example, I mean, there's a lot of programme planning that goes into kind of, you know, setting these implementation timelines. I would say that they are the programmes that I am probably most worried about, but I'm also feeling more confident now with the revised and the mitigations that we've put in place, that we have the processes in place for that. But I'll be honest, that is using the relationship and the routes through the chief executives to get to that level of confidence as well. So we get that shared sense of ownership in terms of, you know, ensuring there's line of sight and visibility within every organisation, actually, I think. So that's where the confidence would come from. I think we have robust internal governance arrangements, because all of the programme boards who have an independent chair appointed by Welsh Government mostly, they report up to our portfolio oversight board that I chair, so that we are managing the whole of the portfolio and some of the kind of, you know, cross dependencies that we need to have in place, and actually we need to unblock at times to ensure that our commitments are held there. So and of course we've got the programme delivery committee that is looking at all of the major programmes and is updated on a quarterly basis to do that. So I think that, you know, that helps with the confidence, but it's a constant in terms of managing kind of the scale of change and the scale of delivery that we've got. But we have the transparency and the oversight in place.
Okay, thank you. On this point on, I suppose, where the confidence comes from, do you think your chief executive colleagues would agree that the issue stems in the planning, not just in the delivery?
Yes, I would agree. Yes, and it's about as Ruth said, the being really clear on the discovery up front. I think then balancing that with the fact that we're holding risk in our legacy and commercial contracts that give you a deadline that you've got to hit. There, you know, that is challenging. And when you think about the pressure on the operational teams, who are the people who are going to experience the change, deliver the change, and often other people who are doing the testing, that the systems are safe to. So that there are so many external factors to this, and some of that, I think, the challenge around those deadlines that are not necessarily born out of the plan. The plan has got to hit the deadline, isn't it? So you're balancing kind of compressed, kind of what perhaps some of our colleagues would want longer in terms of testing and longer in terms of the configuration. Actually, we don't have that time in the plan for a variety of reasons. So it is a constant balance.
Nick's going to come in on the app, and then James will want to come in on some clinical questions.
Hi, Nick Wood, Deputy Chief Exec, NHS Wales. So I suppose you could argue that the NHS Act, from a patient perspective, is probably the most important digital development that we're likely to see. I mean, it's, you know, we've long waited for the accessibility to things like appointments, prescriptions, where you are on the waiting list. But it's been mired in delay, non-delivery. You know, you talked about you can now access waiting times if you were referred from December onwards. Well, there's 653,000 people who are already on the waiting list, so their detail isn't on that waiting time. So I'm just interested from a patient perspective, when are we going to get to the point where we've got a fully functioning, patient-friendly interactive app that people can put on the phones, because at the minute people are clearly not adopting it because it's not there for what they want it to be there for. And I think you've got Q4 milestones that need to be hit.
Yeah.
You know, when are we going to get to a comparable place that there is across the board?
Come to Sam with a comment. Thank you. Sam Wall, Director for Primary Community and Mental Health Digital Services. So basically we increase numbers to increase in value. So you're absolutely right. Prioritising the must-haves and the useful services, that's really important to us. So currently you'll probably recognise when you look at the app that there are lots of independent features on there that they don't actually all link together that well to provide that service, that end-to-end service that people want. So there are some things which are really key to that. So you're right, the waiting list and getting as much information of that as possible, but also things like proxy access. So our carers can look after people, our parents can look after their children. Again, another critical delivery in that. But we have to focus now on the app for designing for everyday interaction, so not individual tasks. And Helen mentioned that we're moving to that product operator model. Currently, the app has been a programme for a number of years. Through the operating model, what we do is that incremental improvement all the time. We want to get to the position that we actually do have in our vaccine space, where we are delivering small incremental value to patients literally every couple of weeks. So whilst we might see that that whole end-to-end piece might take us a while through some of the services, they will get something much more regularly now. So we want to be in a position where you have the app becomes always their healthcare. That is that thing that you always have in your hand that will take you through your journey. And if you think about when you come in and out of healthcare, you don't just drop in and then you leave. You have a journey where you will come back and forth, and actually the app should be there throughout all of those different interactions. So whether that's when you enter it through primary care, you have a referral, you're then an outpatient, you should be able to interact with that app throughout your journey. There is something really important about how we do that discovery up front. So again, that thing that Helen talked about, doing much more in the discovery space. We absolutely need to get a really good backlog of what it is that patients need and would find useful from the app.
Can I just ask how you find that out?
Through user-centred design and user research. So we've invested in that quite a lot over there. I'm the board champion for user-centred design.
Can you explain what that is?
But user-centred design, absolutely. So it's I was going to say don't start me. User-centred design. So what that is, it's a range of professions that are specifically there to understand, firstly, to really be able to understand what people need. So they don't ask you what you want, they don't ask you what you like, they try and work out what is it you need to do, and let's understand how we can do that, because there might be 10 different ways of being able to answer that question. Let's find out what you really need to do. They also specialise in things like, again, really quite boring, but information architecture. When I'm looking at the app, where are my eyes going? What do I expect to see when I'm on that space?
I understand what you're saying. I have some familiarity with what you're describing. I guess my question is this: if I'm a patient, on to the next point. So the point you're making about incremental improvement is good and inevitable in a sense, but it's understood. There'll be a critical mass of availability and value, as you put it, on the app, which enables us to say to the Welsh public, it's basically there. It's basically the app is where you go to find that, whatever it is. Nick's making some points about things being available but not used, differentially available in different parts of Wales. That's a limitation on us being able to say to the public in Wales, the answer is the app. Because if it's not the answer in one health board, people will lose confidence that that is the solution. So there must be a point where you're thinking, this is the time point that we will have got to that critical mass, and all the incremental stuff will have been before that and will continue, but that is the point. What is that time point?
I think it's really hard to put a time point on when we'll hit that critical mass. I think what we'd be aiming to do is to increase the usage monthly. So what we want is monthly returning users. So people that come in every month for something that they would use, we'd want to really aim for that. So there's a whole list of measures from a digital point of view that we'll be looking at to do that. So things like, can people complete their journey on the app now? So can they follow the journey that they want to go on? Also, the types of people using the app. So to come back to what you mentioned about equality, are we excluding any people from using the app? Is it geographical exclusion? Is it an age exclusion? Is it people from certain backgrounds? And how do we then go after that to make sure that we're up in the usage? So there is already a lot of utility on the app, but there are some people that don't use it. So that measure is something we would want to go after to make sure that however we enhance even the things already available on the app, how do we make them better so that they can be better used by people? If you were to say, well, when will the app be finished? Never.
Well, I'm specifically not the question I'm asking, because I do understand the answer, but the question is never. But the question is slightly different, isn't it? When are we able to say to the public the app is the answer to that particular question? But can I just, before you come in, Van Link, do you want to talk about?
Yeah, I mean, I get a sense. I don't mean to sound harsh. I'm not getting a great deal of confidence that we know what the critical path is for the app from that perspective of it's the interface that the public use, and we can advertise that's where the public go. It's sounding more and more like what I think it was called My Health Online that we had in GP systems a number of years ago, which just, you know, that this was the answer and it fell flat and nobody used it. And you talk about more people registered. There's hardly anybody in the population who are registered and are using the app regularly. So you've got to have a critical path to get to the point where it becomes the de facto point. And I really think we need a timeline for when that's going to be.
Would like to come in on this with
I
think
Steve Helen probably start and then come in on.
So I recognise some of what you're saying there, Nick, and we've got 20% of the adult population that are registered, and there is now growing utility in it. But I think we all recognise that actually what we need is to describe and understand what role has the app got in the way that we are redesigning services. So setting out clarity around what are those pathways, what are those kind of functions that need to be there that support our patients to manage their journeys, and that we're all collectively behind those as the priorities. I think that's a bit of a gap at the moment. That's been picked up in the community by design discussions that we've been having as one of the kind of the early things that we need to do is describe what role is the app going to play in designing, you know, integrated services in that space. So I think, and if it's that we and the work around planned care, actually, so where is the greatest value to patients in terms of having more of the appointments or having, you know, backloading the waiting lists on that, then we can absolutely be having that conversation, can't we, and to be setting that out into next year's plan. I think what Sam is trying to describe is actually we will iterate and we will prioritise the delivery, having worked with patients from these are the things that this is the role we wanted to play. So I think if we've collectively got to that description of the vision, then we can answer your question. And I think about the timing.
Okay, we're going to move on to some questions on clinical and patient experience.
Yes, so James Calvert, Deputy Chief Medical Officer. So it's really expanding beyond the NHS app here. So in your introduction, Ruth and Helen, you touched upon the numerous ways in which citizens and staff are changing the way in which they interact with the health service through the sort of medium of digital, if you like. And we're obviously spending a huge amount of time and money on this. Are you able to tangibly and quantifiably demonstrate the benefit of some of that investment, so that, you know, if we were to speak to a citizen or a clinician, they can say that not only is the way in which I work different, it's also better? Do you measure that as part of your development and delivery?
So yeah, benefit. Oh, sorry. My name is Claire Osmondson-Little. I'm the Director of Finance. Apologies. So articulating benefits and values is something I'm really passionate about, as my team would know. And we do, I think, because we're a technical organisation, sometimes struggle to articulate in a user-friendly way what it is the benefits are. So to and also to be consistent in our understanding of what those benefits are, how we've measured them, and to validate them with the broader NHS community, because whilst we create the tools, actually the benefits often lay outside our organisation. So to address that, we've set up a national benefits group that has representatives both from health boards but also from Welsh Government to develop a consistent approach to framing what benefits are, how we manage them, how we set targets, and to use a national system to monitor and measure the usage of our products and our development. We're on a journey. We're not where we should be, and we're working hard to get there. But what that demonstrates is actually, and I've also checked with the other nations, and there is no one who's actually nailed this yet. But what we're trying to do there is be able to not only articulate what the values are and benefits are, but also be able to measure those and also be able to track those across Wales in terms of variation in usage and the opportunity for us to really exploit the benefits they bring.
I don't want to be tendentious, but I think what you're telling me is that you recognise that what I'm asking is important, but you can't do it yet. And you're developing a methodology, or can you give me an example of where you successfully...
I certainly think from the clinical perspective we can, and I'll ask Matt to comment.
Yeah, thank you, James. I think it's an excellent question, and thank you. So I think use is probably one of the simplest ways to show how it impacts staff and how staff are impacting clinical care. So every month with Welsh Clinical Portal, 620,000 patients get their secondary care record access, which is a phenomenal thing to be able to do across Wales, regardless of geography. 20% of those accessing those records, they can also see a summary of the GP record. So you've got that ability to go back into the primary care record and also access the secondary care record. And the Welsh National Clinical Nursing Record is now used across all adult wards across Wales, holds 58 million digital risk assessments. So that's continuously updated. If they come back into hospital, they can look at the last risk assessment for more than 650,000 patients. I think that's probably unprecedented.
Could I just stop you? So first of all, from my own clinical practice, I actually recognise what you say, and my severe asthma was my ability to deliver good severe asthma care immeasurably improved when I could see the GP record. It was a complete phase shift that brought benefit to patients. But I never actually was asked. I was never actually able to reflect my better experience back to you. So that's one of the points I'm getting at. But actually, the hardest thing and the real tough measure is, do the patients feel that difference? And how do you think you could measure that? Is that something you're wanting to measure? How citizens feel rather than just professionals?
Yeah, so I mean, it's quite an interesting research collaboration that Digital Healthcare Wales has been leading, at least in the initial identification of their patients. So we've recently worked with the Organisation for Economic Collaboration and Development in something called the Paris Study, where we identified 26,000 Welsh patients, which was the leading cohort of patients across any country in the world. And through that efforts, we were able to ask patients their direct experience of healthcare. This sort of sets potentially a new way of doing policymaking, where we engage patients in their experiences of care, and we can link that data then also to their outcomes. So if you like, we're pioneering a new model of where we use potentially the app to actually engage patients, understand their experiences, link that to outcomes, and then actually measure our effectiveness of our policies.
That's proms and preps. Is that what you're talking about? I'm not saying that.
It is proms.
Just so I understand that. So, but isn't the challenge there that requires an entire system change in terms of how we apply value, how we make that the driving measure in our system?
Well, because we have the foundations, if you like, of a national data architecture in the National Data Repository, which was invested in many years ago, and now the app, which is a portal direct to patients. We combine that with some of the research capabilities of the OECD are doing. It actually is an enabling thing for the future. It gives us evidence-based policy making.
Okay, thank you. We've segued on to enabling there, so we're going to move on to the second item on the agenda, which is how you're doing enabling digital services. Who would you like to set the scene.
I'm going to confirm my interim vice chair, David Sullivan.
Interim Vice Chair, also Chair of the Programme Delivery Committee. So I'm going to talk about how we deliver enabling digital services for health and care. Across all of those settings, we are working at the moment to strengthen the digital services we provide that support clinicians on a daily basis. We recognise that progress in some areas has been slower than anticipated, as already been mentioned, and that's particularly where we've encountered unavoidable complexity in terms of what we're trying to deliver, either through supplier dependency, local configuration, or integrating with legacy systems, which is a consequence of the fragmentation we mentioned. However, our focus remains on delivering safe, user-friendly systems that are interoperable, that reduce duplication, cut out fragmentation, and better support decision-making. In primary care settings, we're currently working on GP system migrations, pharmacy modernisation, and connecting care. And on these programmes, we're moving to more unified platforms. These changes will improve continuity for patients, streamline staff workflows, and support national priorities such as digital prescribing. In the secondary care setting, our clinical software is used to support patient pathways, reduce and make sure that patients get the right care in the right place at the right time. The way that we do this is through safer information sharing, reducing the paperwork that staff have to perform, supporting faster clinical pathways, and improving data availability for population health. Whilst delivery challenges we've had some delivery challenges on major programmes, progress in areas such as diagnostics, maternity, and vaccination demonstrate what we can achieve when all our system partners are aligned. In summary, our products, programmes and services deliver a more reliable, joined-up tools to support clinical safety. They reduce inefficiencies in the system and enable seamless patient journeys across all care settings.
Thank you, David. Thank you for that. And you mentioned a number of large national systems in your opening. What I'm interested in, Ruth, is when you look at the DHCW budget, how are you as an organisation demonstrating value for money from that, in particular, and some of the large projects that David talked about, and really keen to hear where you have assessed that something isn't delivering the level of benefit that you think it needs to. What have you stopped, basically, or what have you redesigned, and how material has that been?
Yeah, I mean, I think the stopping question is one that does preoccupy us quite a lot, because it's incredibly difficult across a system of collaborative programmes to unilaterally stop things. So certainly there are a number of things where we have recommended the redesign on that. Claire, I think you're going to comment for us.
Yeah, thank you. Yeah, so when you look at value from a budget and a budget allocation perspective, I look at it in three areas. One is taking the cost out, one is improving efficiency, and the other one is creating value. And certainly when you look at the taking cost out, we've taken significant cost out through the way we organise ourselves and the way we work and the way that we procure. When you look at efficiency, it's also about the way that we develop programmes and the mechanism we do that, whether that be cloud-based or through the integration layer. So we're also looking at improving that. In terms of about creating value, that's really about the outcomes that we're trying to achieve with the programmes that we're funded to do. So in that context, for example, where we've stopped or taken a break and redesigned a programme, for example, because in our professional opinion, it wasn't achieving the outcomes it was led out to achieve, was in the case of LIMS, for example, whereby we took a break in that particular programme and reset it with a new contract arrangement and with new programme leads in order to re-deliver that programme when it was transferred to us as an organisation and deliver the outcomes through the overseen by the programme committee. So we do that collaboratively. We've suggested that's not a decision we make for ourselves. We do that in collaboration with Welsh Government, but also with our key stakeholders.
So is there any aspect of activity that you feel actually this doesn't have third parties that are dependent on it or require third parties to be part of the decision in the way that I completely understand what you're describing as a challenge there, obviously. Is there any area of activity that you feel actually, looking at the overall value for money proposition, we should be doing less of that as an organisation?
So as part of building our future programme, we actually did look at how do we improve our efficiency as an organisation in delivery of digital. And what that has really sort of changed in terms of our mindset and delivery is the way we deliver digital. So,
and how has that changed?
So we're moving our operating model to be more of an agile product and service team, which is less technically but more user-centred in its delivery model, which enables us to build teams consistently to own and develop and deliver that product and deliver the outcomes that we want against that, and do that in a more sustainable and cost-effective way. So that's really where I think we'll see a difference. And the only other thing I'd add is that we've also looked at the way that we deliver. So automating testing and looking at the way we develop and design systems has also been a way in that efficiency of value is another area that internally we're looking at to really exploit as we go forward as well.
Okay, so some of the operating model points will come on to in the last of the 4 sections. There's more time left for us to discuss that. But Howard, do you want to come in?
Yeah, Howard Jones, Director of Finance. So be unsurprised with some of our previous interaction, I was going to focus on benefits as well, but we drifted into that space, so I'll just change tack slightly. So 2 things from me. So I understand what you're describing. I've heard about benefits framework, I think it's a conceptual approach you're describing around cost efficiency value. So all of that's understood. Look at the kind of specifics a bit more. So I think there's 2 things for me on that. One is on quantifying benefits and return on investment. Do you have specific measures to quantify benefits and ROI on each of your investments and programs? And then secondly, can you give us an example of some quantified financial benefits that have been realised from investments we've made this year?
Yeah, so we don't have an ROI in all of our investments, truth be known. That's because for some of those we are still working out, for example, the benefits of the adoption and delivery and the time saved, etc. But in terms of benefits,
can I just ask before you move on, why would that be the case? Why would you still be working on it?
Because for example, if you look at something like the app, we've developed the benefits on that. We estimate it's 19 million per annum, and we've got a breakdown of it. But actually, until we actually launch that functionality and look at the outcomes that we've delivered from that, we haven't done that piece of work yet. So we're still working on it.
I think that comparison programs, but yeah, there is some of the unquantified ROI will be on some of our legacy, our older programs. I think there is something for us to do collectively as a system on really understanding the health economics of the investments that we're making in digital, because it's not necessarily these are not cash flows most of the time, the benefits that are being realised, but actually what you would aim to be doing is adding value, and that's through improved outcomes and through the efficiencies in that space. So I think that there's a real focus on it on this, and I guess the other point to make is that it's quite difficult to see this in any system, because we are looking and trying to understand how we can learn from others, but driving kind of realisable benefit from digital is quite a tricky thing to do. That's not an excuse, but that's.
Is that in the model that you're using, though, or is that inherent?
I think it's inherent, because actually some of the stuff that we do is it would be like asking what are the benefits of having electricity or having water available to run our services, because and I would take, again, sorry to harp back to diagnostics, but actually it's probably a good example. What we're really focused on at the moment are 2 major critical infrastructure replacement programs. So the benefits are not going to be material after significant investment, but if we don't actually have those systems in place, we can't actually run health services. But what they will do is that they will provide the platforms from which we can innovate further, and the opportunities around the data and AI to actually really transform those services will come kind of as part of that. But the actual programme that we're on at the moment, it isn't going to realise that much to be a benefit.
Okay, thanks, Claire. Do you want to come back?
Yeah, so back to Harold's challenge about can you demonstrate a programme that's delivered return on investment this financial year? The one that I can demonstrate has made a return is in the Welsh Nursing Care record, where in Q1 and Q2 this year we've delivered £0.5 million worth of equivalent savings. You will ask me, I know, is that cash from Sinclair? No, it's not, but it is time saved, as Matthew alluded to, for nurses using our Welsh Nursing Care records on the wards. But so that's just one example of where we've got that, where we've got the measures and where we've got the monitoring, we can demonstrate the difference we make.
Howard will want to come back in, but I'm coming at this from a much less expert position. But would you expect that to be an approach which you take for every programme, apart from some of the legacy ones which Helen was talking about?
Yes, and that's why we've been set up that national group, because we do want to demonstrate of the value we can create across the system, and do that in a way that is measured consistently, and the targets are agreed, and we're able to articulate that financially. They're not just financial benefits, though. No, that's the other bit.
Of course.
So for me, that is a really important factor, but actually it's also the social and economic benefits.
Yeah, no, I think it's a broader definition of benefits, certainly. How did you want to come back here?
Only very briefly, because again, picking up the same space Cabinet Secretary, but challenge of quantifying benefits of infrastructure investment understood, legacy issues understood, they won't all be cash releasing understood. But I think in the way you described it, look, we've made some new investments this year. This is an area where increasingly as a system we'll inevitably make some investment in the way the world's moving. So there's something to be around methodology and approach. So understand kind of the mechanisms you've got in place. Do you have a clear framework for each new investment, identify the benefits, the ROI, what is quantified, and that is something that we can expect more of as more investment goes on to the agenda?
Do you mind if I just expand on that? Because it's so frustrating to listen to, because I actually think you're selling yourself short in that area. So something that I was very involved with at the business end was the implementation of EPMA, where I think you had listened to stakeholders, you had poured clinical time into the beginning of the programme. When I took EPMA to the board, I had a really clear idea based on your methodology for how I could sell it. So 5 minutes per discharge summary, better stock control, all of those things. So we were able to do that because you had built into that programme a methodology for understanding what the user wanted at the end, right at the beginning. And I really want you to articulate how you're going to extrapolate from that to the programme.
Absolutely, you're absolutely right, James. And for me, we're at the cusp of it. So, for example, it's now as those programmes become operational, which will be over the next 12 months, we will absolutely be able to demonstrate the difference that digital makes. At the moment, we don't have many programmes that are going live that we can really demonstrate that difference that we make. But you're right, we have got capability going forward.
What Hal was wanting was to understand that what I've seen in EPMA is now part of your methodology and will be lifted and shifted.
So yes, Ivan is desperate to answer this.
Yeah, well, thank you very much. I was going to refer to those. Now, usually there's a business case that has been set by the government, and that's the basis of the investment from Welsh Government. Now, it was slightly different at the time, and we got that money without the business plan because of the price. So I worked with the Chief Medical Officer at the time. We don't need to convince ourselves that we need to digitize. So the framework was developed around benefits and value after establishing the DHCW. So that was part of the brief. I think our expectation is that any new business plan would include a benefits framework or a value framework. That would be the basis of the investment. But what we are seeing is that everyone wants to promise the benefits just in order to get the money. And then at the end of the process, yes, we've completed the program, the digital system works, there's an improvement in health services, but let's account the benefits. And there's some nervousness then around the time that has been saved or the benefits that have been created.
Realise the savings.
We need to realise the savings.
Generally the principle.
Yep, I'm on processing.
Yeah, and that is a process that we are currently working through. What we are trying to do with the next wave of programs and using the benefits framework that has been agreed, but to put that into the digital systems so that the systems track these benefits automatically. And just one very, very brief comment as well. I think it's difficult to stop digital developments. You know, the direction is to use more digital rather than stopping things. So I would describe it more as changing the way we do things. So certainly, if we want to look at, stopping things in our own data centers and moving things to the cloud, then we see huge amount of savings over the next years. Another live example is the work with Microsoft. We are negotiating on behalf of Wales with Microsoft. It's a significant system, and we want to work as one system to negotiate this with Microsoft. By doing that, we can negotiate a better value than the general price that has been set by the Cabinet Office. So if we compare it with the Cabinet Office, we can see very clearly how we can move from stopping the current methods and doing their own cybersecurity and doing their own storage. By centralizing everything, we are seeing significant savings.
Very good.
So I think that changing the method or the approach is better description than stopping to do something. It's not easy to switch things off.
So I suppose linking some of these points on the stopping and the difficulty, it would be good to hear your reflections on how you take lessons learned from the programmes in track, recognising a number on the horizon for completion, and we talked about the confidence around the delivery, but something about how do you take stock of the benefits delivered to stakeholders? Normally the benefits are in the health board and patient space, so how do you capture that? And then how do you take that thinking into new programmes? So because there is a tipping point where actually if we have delays and reprofiling, the benefits reduce, and there is that learning from existing programmes needs to play into future programmes. So that we don't go over that tipping point, that if there's a kind of 20% margin that gets wiped away because it takes longer to deliver, the benefits might be zero by the end, at which point if we'd have known that, we'd have never started. So how do you take that challenge and the experience from the programmes to date into the conversation when we go, we need an X or Y?
Let's start with that, and then perhaps I'll ask Chris to comment on some of the lessons learned that we've captured over the last year.
Yeah, no, so there's a kind of just to explain generally that we have a learning approach in the organisation. We've got a learning group that reports into our digital governance and safety committee. But and all of our kind of lessons learned as well as incidents and all of that will be investigated and overseen by that group. But I guess there are we've undertaken a number of gateway reviews and lessons learned exercises in terms of resetting some of the programmes, and there are a lot of consistent themes. So we've done a thematic analysis of all of the lessons learned. I think you're right, Alex. I think there is a lack of appreciation that continuing a programme is something that doesn't have a consequence financially, when actually the act of running the programme is actually quite an expensive exercise. That is becoming more understood now, and we are absolutely being more clear, or we're being clearer about the fact that actually continuing this for another quarter and the decision to need to move things forward, or you have a choice where you put more resource in to actually deliver it. I think that is a more transparent and open conversation, and we understand now the inherent costs in programme delays. That is feeding into the processes, and I know Chris will talk about our escalation plan, but one of the deliverables as part of our escalation plan has been to do a lot of work in describing and designing the typology of our programmes and projects, and how we assess up front what it is we're trying to achieve, what the scale and scope of it is, and what that looks like in terms of how we organise and design the programme to deliver it. What does that look like in terms of the financial framework, so that we have the right contractual approach in place, because we have a variety of contractual approaches here that can be quite challenging when we're looking at national implementations. So we're trying to upfront, again, this is about better discovery, and discovery is not just about sort of our technical colleagues doing that upfront discovery. It's the whole programme design that we really understand from the outset. We're trying to achieve this. Here are some of the dates that need to be met because of the risks we're trying to manage, and actually we think the design is this. But we can now also play into that. If that goes over quarter, 6 months, whatever that would be, actually that we will be able to quantify, and based on the benefits framework we've built that in, actually what the cost is. That wouldn't have been the case for the programmes that we have in play at the moment.
I'm conscious of time, so we'll move on to the third item on the agenda, which is about how DHW is supporting staff the effective facilities and getting services ready for the future as part of that. Who's going to?
That would be,
Good afternoon. My name is Rowan Gardner. I'm one of the independent members, and I chair the Data Governance and Safety Subcommittee of the board, through which we provide assurance to the main board. So we know that delivering digital safely requires robust, resilient infrastructure and systems that adhere to national standards. Cyber threats are increasing, and we prioritise strong cyber protections where we lead. But ultimately, resilience is a shared responsibility across the whole system and requires continual investment. There is a shared opportunity through national architecture, through data standards and integration services to simplify a complex estate, which takes cost out, but it also reduces risk. And the national data resources delivering more advanced analytics, research opportunities, and safer, more joined up care. It also adds, greater cyber resilience through just delivering the main project, something that isn't factored in as value, as we've been talking about how we find value in these programs. So thank you, and I welcome your questions.
Thank you. I've got one main question here, really, which is what would you say are the main cyber and operational vulnerabilities that you're responsible for managing? And mindful of the point that you just made, which is that the implementation of some of these solutions aren't directly in your hands. There is still a system leadership role for the organisation. So what steps are you taking to make sure that those interventions to tackle those cyber and operational risks are applied consistently across health boards? And in relation to AI, that is accelerating locally before national approaches are put in place. So what needs to be done specifically to make sure that as that happens, it's happening in a way which is minimising risk and making sure that the legal compliance and other requirements are being met?
I think we'll probably start with cyber and then come on to AI.
That's okay. I am a life science AI professional, so I'm across a lot of the areas that you are interested in. So let's start with we assure the board, and if you've perhaps had an opportunity to look at the videos of our DGNS committee, the Data Governance and Safety Committee, which we put up on our website, you will see that there are matters around information governance, learning, some of those good things that we do in public. There are also cyber issues that we take in private. This is a public meeting, so I'm not going to get into specifics that puts both systems and the public at risk. That said, DHCW does have a role and does support the wider system through the Security Operations Centre, through the Cyber Resilience Unit that provides those, support to the wider organisation. But, we can't assure what other organisations are doing.
I'm asking a slightly different question. So I know that you can't articulate the risks, and I absolutely understand and agree with that approach. I'm trying to get a sense of what the organisation regards itself as responsible for managing in the cyberspace, and what steps you are taking around that.
So we are responsible for the cyber protections and systems around the systems we deliver into the service. That the risks there would span both users, so people are a huge source of risk, so we need to train people. There are other steps that we will be taking, and we're happy to follow up offline on that. Then there are activities that we look at: systems monitoring, recovery, business continuity planning across the systems that we deliver. There is a real need across the entire system to work together and be more joined up.
I think I'm going to ask Helen at that point to comment on the wider system,
And the AI point as well, if you want.
So on the cyber point, I absolutely see us as having a system leadership role in the wider system protections. So as Roland said, we've got now a national monitoring and security event and monitoring system in place that actually scarily shows us where all of our the attempted kind of penetrations are across the system. We bring together on a monthly basis the Caldicot Guardians, who are the people who are responsible for kind of data in organisations, and the silos, which are the information, the responsible officers for information in organisations, where they're talking about the cyber risks and the threat levels, because the threat levels are really high. We can, we all understand what they are, and they are prevalent right across kind of globally, particularly kind of our threat levels came to the UK. But we're working with Helen actually in the team, because we feel that cyber needs a national governance board where the minimum service levels or minimum specification, minimum standards are actually being measured and monitored, so that we are clear what levels of cyber security that we have in Wales appropriately in the right fora, and that through the CRU, which is our Cyber Resilience Unit, which we do on behalf of government in terms of the audit of the cyber posture in Wales.
What does that mean, cyber posture?
Cyber posture is what level of the assessment through the CAF process. Sorry, so many acronyms, but it's an assessment of where you are at particular domains that together will get you to a score that says what your cyber posture is. So
how safe you are, basically.
Yes, how safe you are and how much risk you're prepared to accept.
How you can recover, because that's the other point, isn't it? There are two kind of main points to the cyber agenda. It's the protections that you have in place. A lot of that's about people and hygiene factors, and it's then when it happens, how will you recover and how do you minimise the harm and the risk?
And on the AI question, I mean, obviously, there are decisions being made every day throughout the NHS in different health organisations about deploying AI. We are developing national approaches. How do we know that what's happening on the ground is done in a way which is safe and sensible in that broader sense? Obviously, people are making, highly paid professionals are making these choices. But from a system point of view, how are you forming a view as to what's happening in the AI space? Is something we want to guide in a particular way, encourage, discourage? What's your approach to that as an organisation?
Yeah, great, Josh. We've been very much from Mike Kennedy earlier forward to the on Sanjay Trust system.
I think the national framework is the way around the system. I think there's real enthusiasm around the framework. People are embracing artificial intelligence, AI, and they are doing that across the system. And I think no one is really, everyone's competing to get the framework in place as soon as possible. Now, the framework have set a direction to the system saying that every organization has to comply with the guidelines and regulations that have been published. I think over the last 3 months, we have drafted principles for using AI responsibly, and those guidelines have been supported by the digital director of every organization. So I think the next step now for us is to move to a clearer framework. There are examples. For example, a network have published a framework recently, and we meet regularly with the leaders in Northern Ireland and Scotland. So we are keeping an eye on what they are doing. So I think the key thing, and this is why the framework is helping, rather than having a central process. And this is the feedback we're getting, of course. We need a balance between regulations in the framework that are detailed enough to give assurance that things are safe, but not too strict that people are trying to avoid them. Because, you have shadow AI then, and that is outside of our view. It's a shadow AI, and there's risk then around data. And some of the agencies and some AI systems have access to this data. So I think all of us need to move very, very quickly over the next few months to put something in place that is fit for purpose and strikes the right balance that people are willing to use.
On to the fourth and final section of today's discussion, which is how you're strengthening the work within the NHS. Who's going to be on that?
Marianne Wynne-Jones, please. Yeah, thank you very much. I'm Marianne Wynne-Jones, an independent member and chair of the Assurance Committee. Now, we've already touched on how we strengthen the organisation. So can I take this opportunity to summarise some of the points during the meeting this afternoon? Now, we have recognised already that we've deliberately gone about to strengthen our governance of programmes. And we've heard already that some large collaborative programmes have faced some significant challenges. However, as an organisation, we have responded by improving how we escalate issues, how we provide assurance, and how we work more effectively with our partners across the system. And it is a very complex landscape. Collaboration is not always easy. However, we have made a real attempt to rebuild our relationships, rebuild trust, and improve engagement with health boards and other partners and stakeholders. We have commissioned an independent report of our relationship with stakeholders. Audit Wales have also done some similar work, and the feedback has been honest. It has also helped us to perhaps shape more effectively how we progress with our improvement plan. And that is leading to better co-understanding. It improves our working relationship on a strategic level and practical. And on top of that, we are working very closely with chief executives of the health services on developing the digital blueprint and how we also do joint planning and how we deliver one digital system for the people of Wales. We've got a new implementation model, and also culture change is an integral part of that. But we are also placing clear objectives, cultural objectives around collaboration and respect. And in conclusion, we are committed to transparency. That is extremely important. Now, we publish all board papers and all committee papers. We also record all our meetings and we stream them on our website. So what's important is that that allows our partners. It also means that the public can also view exactly where we are. Are we on the right path? Where the risks are? But more integrally, how do we react and how we respond to those risks? So continuous reporting and honest reporting is an integral part of how we operate, and we are fully committed to maintain that. Thank you.
I'm keen to look at the touched on this in a number of points already, but the delivery model for the organisation. It's a time of reflection for the organisation in the way that we've touched on in many ways already today. It's a rapidly changing landscape outside the organisation, both within the NHS and in the technology, digital, data, AI space as well. So I want to get the board's view on whether you think, whether you feel that you have the right leadership, the right digital skills, the right commercial capability, the right mix of, balance in the organisation to deliver those ambitions. And have you identified in that mix, at all levels, I guess, in the organisation, in the usual way, any gaps that you need to be able to fill, and what are you doing about that?
Yeah, thank you, Diolch. Helen will talk about our Building the Future programme and new operating model. I would say that is all levels of the organisation, so it's given us an opportunity to look at how, as we make changes through the organisation, that means we need to, strengthen our leadership. What additional skills do our leadership team need? And that includes around our board table. So when we talk about the Building the Future programme, that encapsulates the entire organisation from that perspective of reviewing the capabilities that we have.
Thank you. Yeah. So we spent, the first thing to say is we spent a lot of time in the design of the new operating model, and it's not just kind of a design and setting out a structure for the organisation. Actually, it's been a review of kind of every layer and every role and every discipline. Actually, so
could I just ask you, because conscious there'll be people listening who won't know about the operating model. Okay. So could you just say in a couple of sentences what the old model was and what the new model is going to be?
So our old model was probably more akin to a more traditional IT and infrastructure, software development and information and data services over here. What we're looking to do is, and what we are doing, is stepping into a service-led operating model that delivers, an example would be for vaccines. Actually, we are delivering a service for vaccines. One of the projects and the project teams that deliver that will deliver in their will deliver the vaccine system, but also that service owner will be responsible for ensuring how we surface the vaccine appointments or the services into the NHS Wales app.
So it's the implementation
as well. All end to end. Okay. It has autonomous teams. So these project teams then are autonomous and they have the skills in them that we need. Very much kind of stepping into an improved focus on user-centred design, which Sam explained earlier. So we're starting from a point of, whilst we've always done that user kind of, worked with our users on the design, actually we've not necessarily adopted the user-centred design discipline, which is, inherent in that digital way of working. So I guess what we're doing is shifting the organisation from what is the more traditional kind of IT service-led organisation into a truly digital organisation. That's what we've said.
And what's your assessment of the capability, skills mix, all of those questions?
Yeah, so we've done the design, and through the design we've underpinned that with a career framework. So we've taken the government digital and data career framework. So this is aligned then with the rest of the public sector and industry in terms of how we are redesigning the roles. And what we're the Building Our Future programme, which is what Ruth touched on, was the kind of transformation programme we put in place to support the organisational change. So how are we going to bring the first steps? How are we going to bring those teams to life, if you like, and move and match our every one of our staff has been matched into a new role description, a new job description. Now we're at the stage where how we're going to work, what's the ways of working that actually need to be changed. And we talked a lot about agile working. What that means is, and it's not a new phenomenon, and we've used agile working, but actually in the digital sense, we're talking about continuous improvement, because we spend a lot of time talking in the digital world about programs. Now, programs are a kind of, a finite thing, aren't they? And they start and end. And normally there's a little bit of funding to maintain afterwards. That's the traditional way that we would run kind of IT services. Now what we're talking about is actually having teams that are funded so that they're constantly iterating and improving and working with users and being really responsive. So the pace to value, if you like, is far more frequent and is reflecting what users need, which was Sam's description earlier. So there's some big changes in that. So some of the skill mix that we've been looking at is how are we going to support our technologists now to actually move into a completely cloud-first operating model, because that's where we're headed with our cloud programme. Our data scientists to really embrace the big data capabilities that we have now, so that we can really start to harness the opportunities that the data will give us through the National Data Resource to actually drive that forward. So there's been a mix really of, we've been working with our academic partners on some of that training and insourcing some of that. We've got agile coaches in the organisation at the moment so that they can work alongside teams. They're doing assessments on our teams at the moment to understand, in terms of a best practice approach, where are we now, where are the gaps. They've actually done a RAG rating for us, which is really helpful at every team level, because of course this is about people. There's a lot about the technology, but most of this is about people. Digital is, people, process, and then the technology. So it's really understanding where those gaps are and how we target some of that kind of upskilling.
And so from the point of view of the shape of the organisation,
yeah.
So just in terms of, there's been quite significant workforce growth in recent years. So we're looking at the thing, and it's relevant to the point you're making about a changing organisation. So. Yeah. Does anybody, between 2021 and 2023, anybody have a sense of how big the employment growth was in the organisation?
Yeah, we went from, I think it was around 850, and we've stepped up to now to about 1,200.
Yeah, so it was 25% growth in that period, and it's continued since then.
Yeah.
The average, the NHS in Wales is at its most staff ever, and the average workforce growth is 2.7%. Against 25% for that period. That's obviously unsustainable. So what's the organisation going to do to address that?
Yeah, so shall I kick off and then bring Claire in, because she'll talk about the detail of that. But the biggest growth is going to be in the development funding that we've had in to take forward major programmes, and part of that was inheriting some of the big programmes that were with us to start with. So it directly correlates, or the majority of that growth is correlating, not just with the setting us up as a board, but actually with the additional work and priorities. Now that we've got an SHA for digital in place, actually, we've expanded the digital investment, and that's necessitated then the growth in the workforce that we've seen.
But would you agree with me that that level of workforce growth is unsustainable?
Oh, yes.
Okay.
Yes.
So if that is the case, what will the organisation do?
So if you look at the growth, actually over the last year, the workforce growth hasn't grown. It's remained around about 1,200, and that actually reflects the funding for the digital national improvements, which has actually driven a lot of that growth. So when we started as an organisation, our digital funding, or our development funding, was about 13 million. That's increased to 34 million. A lot of that is with health boards and trusts. So if you map the workforce growth with the funding growth, you'll see the correlation. That growth is that funding isn't going to grow any further. And actually what you're seeing is, and you've seen that growth because we're starting to stabilise, what you're now seeing is actually the implementation of a product and service-led organisation, where actually those skills and development to maintain those digital products and services will be within DHCW.
And are they?
Yes.
You're saying that they are.
So it's
a big shift. I'm asking an open question. It's a big shift in the model. it requires a different skill set, presumably.
Absolutely, yes.
And you're saying that's already in the organisation, or you're saying?
That's the building our future development that Helen was alluding to. So we're moving, in fact, from a programme type organisation to a continuous improvement service delivery organisation. So there is a switch in terms of that. And we've started to see that switch because, you know, the cancer programme, for example, is no longer a programme. It's actually part of our operating model, and we've integrated that into the skill settings of DHCW. So that's the shift that we're making, is that we want to deliver digital in a far more efficient, effective and user-centred way. And that operating model will deliver that.
Okay. Is it, and I don't want to put an unfair question, but would you say that that level of expansion has been mirrored in an expansion in the output and the benefit the patients are feeling?
So I think that goes back to James's point, in the sense that we have developed some of those key deliverable tools now that will, over the next 12 months, go live and be implemented. So it would be lovely to sit here and be able to demonstrate the value that we are given, but we will be able to demonstrate that as DHCW. Yes. Okay. So I'll bring Helen, and then perhaps you can.
Yeah, Helen.
Back in.
You're going to go where I'm going as well. So, and again, this is a bit of an unfair description. There's been almost a bit of a transactional. We've taken on a big blob of work, so we've got a big blob more people. So in your new operating model, as you know, projects and programs ebb and flows, how is your model built in that ability to ebb and flow, support different projects, so that we don't always say, well, anytime we take on something new, that requires another shift in the number of people we have.
Absolutely that. And this is a balance to be struck at the moment, because of course some of those, that growth in staff is not permanent growth in staff either, and it's predicated, and some of it is, and predicated on short term, well, I say short term, not long term funding then. So, but the whole kind of ethos of the model is that we will have people with the right skills and expertise to apply to the work that's needed to be done, rather than we have a technical expert in one system. Actually, we have a team, and then we have communities of practice that actually will rotate in and out of the teams at the right time, so that we're not having this lag time that we have from a programme perspective. I'm not saying this is going to be done overnight or it'll be perfect, but not having that lag where we're going to recruit a load of people to do kind of this, you know, and get up to speed, where you're 6 months through the first year of funding before you've actually got people on the ground. Actually, that we can find the balance where we have the right skills in place and we prioritise and focus those skills at the new priorities. So there's something about, and Alex and I have talked about this, having a bit more visibility together of the demand and where we think we're heading in terms of the capacity we're going to need, so that we can have more surety in that. Because currently the arrangements are can be, I guess, inefficient, because these are, again, we come back to people at the end of the day, and we've got people who are on fixed term contracts. About 10% of our workforce on fixed term contract. That's why some people like the flexibility. That often that is quite an uncertain place for people to be, and if there's no surety in the funding for the programme coming next year, even though we know that actually we're going to want to continue that endeavour collectively, we end up having this disruptive effect then, where we have the turnover of people, you know, even if they're turnover within our organisation at that point, that we're seeing disruption to some of the programmes of work, which is impacting us. So I think there's a balance here, Helen, I think, in terms of us having the right skills in the right place, but the operating model, we firmly believe, will allow us to do that in a far more open and transparent way as well.
Although I think, sorry, I think we've got an actual example of where this works, though, don't we? And I'm sure Sam is going to tell me if I'm wrong on this, but currently in the move to new ways of working, we've got the team that were on vaccines who are now then working on in just that example.
Yeah, so we've got. So apart from obviously having people that can do that, can work in this new operating model, it's really important to have them trained and skilled in that area. They're also using techniques that we would want them to use. So creating repeatable pieces of technology that can be reused again and again, because that will cut down on time that it takes to get those things out of the door. So that's a key part of training our people in this right way, in this new way of working, bringing people in with the skills. And we have really invested in that, not just in numbers, which you've seen, but also in the training and the coaching that we've given them. We want them to work in the way where we can automate more, where we can repeat the tools that we create and use them in multiple places. We wouldn't want to, for instance, be creating on every single thing that we do a new booking system. You create a booking system that's really good and then you deploy it across all of our services. Because actually, why would we expect our patients to have to learn to book in a different way every time they want to book something in the NHS? They should be able to recognise something and say, I know what I'm doing, that's a booking system, I recognise it, it's an NHS Wales product. So this is a big part of how we want to make that change, and that efficiency will come.
Will that allow you to, as an organisation, to start to shift your balance between, in effect, the work you need to do to keep the wheels on and the continuous improvement?
Yes.
And then the more developmental things, what's the next new thing, and be able to bring things online more effectively.
Yeah, no, absolutely, Helen. That is exactly where we want to go. The keeping the lights on is always really important, but as people who tell you, digital is important as hot, cold, running water now. We keep talking about digital as this separate beast that happens somewhere else. It isn't. It's just how we do business now. So we absolutely want to be able to get that basic stuff that we do to be repeatable, to be done again and again, so we can move into that innovation space and to keep finding that efficiency, keep pushing that value for the patient in much more space. I think, just in some of the small things, I'm primary care, so I'm going to say this, obviously, some of the things we've done in the primary care space with things like vaccine, where now we have patients that can have the co-administration of vaccine. They only need to go once. We've had 132,000 people this year that have had flu and COVID at the same time. They haven't had to go twice. They haven't had to book twice. And our doctors and our nurses haven't had to administer that twice. That is that's just one of those repeatable things. We can use that in vaccine again and again. Whatever vaccine you bring online now, we can consume that into our vaccine system and roll it out.
Can I just ask, Ruth, what's the mix between build and buy in the new model?
So there's no kind of predetermined kind of mix of that. So there's a couple of things with that. The choice is about the options that are available to meet the requirements. So what's the problem we're trying to solve? What is the best way of solving that problem? And we do that in an open kind of, appraisal of all of the available options to understand what's the best way of doing that in our context, I think is also really important. So someone's described in there, the vaccine system, it was born out of the COVID response. But at that, I remember writing the options paper myself on that when we were doing it, which was we've got a child health system that's got a vaccination and immunisation module. Is that the quickest way for us to scale that up so that we could support the vaccine programme? That's what we did. We ended up re-platforming that. And it's been hugely successful because we are reflecting back actually the direction of travel that Wales has wanted to take in terms of policy, so that we've been able to respond to that, I think, hopefully really effectively to support that.
But is it fair to say, and just tell me if it's not, but just try to reflect on some of the conversation we just had about Helen, the way Helen put it was keeping the lights on. We've all said that fairly once, and then developing new innovations. Is it right to say that the more the mix for the future is on the build side rather than the buy and adapt side, that you're creating more keeping the lights on challenges for 10 years' time?
I mean, that's where the work on the national architecture probably comes into its own. I think we've baselined exactly what the estate looks like in NHS Wales. Now it's about describing what that future state is and what does that roadmap look like to get to it. So at the minute, we are continuing to maintain and improve our existing legacy, whether that's with our supplier partners, and we have strong, we commit to creating strong relationships with our strategic suppliers, but also in-house, because we have those systems and teams in place currently. And some of that improvement is about stripping out some of the stuff Claire was talking about. It's about stripping out the cost inherent in some of the legacy estate that we've got, because digital inflation is a real challenge for everyone, particularly for us in Wales. In fact, we're next Tuesday we're talking to the chief execs about it, because it's such a a huge issue for us. So there's no kind of build or buy is the option in terms of the decision to be made based on what's the best option in actually solving the problem.
I get that. No, that sounds like a sensible approach. But is it right to say that the more that you end up on the build side, the more that you're creating? I'm not being critical. I'm just asking. Are you then creating more keeping the lights on challenges in 10 years' time because you've got a bespoke program that requires a particular skills mix and is not then able to adapt in a more fluid way? Is that a fair question? And if so, are you asking it to yourself?
Yeah, I think it's not as binary as buy or build,
sure,
because I think it also is we buy a lot, but we customise a lot of what we buy. And so exactly those problems that you're characterising are problems of that ultimate customisation, which has happened a lot across the fragmented system. So it comes back to the fragmentation point as well. So there is a line of where we go to. But Sam, I think you wanted to.
Yeah, I think so. I think before you even buy or build, the first thing is what can you use? Yeah. So I think reuse is a really important one. In vaccine, we're reusing what we built in vaccine to rebuild our Choose Pharmacy platform, for instance. And those people that are using those technologies, they're common technologies. They're technologies that if we were to go out to the market to look for someone that can code in this technology, it would be well-known modern technology that we would find people that can do this. The issue we have with our legacy technology is that you are right, there are just a few people that know how that thing was put together. We don't do that anymore. We put things together in a very structured, modern development way, where I could get someone from a university who would say, I know what that's written in, I understand that.
Yeah, thank you. Ruth, I think we've reached the end of the 4 items on the agenda. So there is a couple of minutes if you want to throw anything to our attention that you've not been able to before I set up.
I think this has been a really helpful conversation today, and thank you for the opportunity to discuss the items that we have. The one piece for me that we haven't touched on, we've touched on it slightly, is actually our the use of the national data resource and its importance to Wales and our role in that, and also the ask that we have of the system for getting the data into the NDR. I was hoping that Matthew might comment actually from a clinician perspective on that for us, so that we can better understand that programme.
Thank you. So primary purpose of the National Data Repository is to collect information and store it in one place so that clinicians across the whole of Wales can access that information. If we do that, we can deliver safer care or continuous care in any setting across Wales. So that's the primary purpose of the National Data Repository, to get the right information to the right people at the right time, to deliver safer, better care closer to home. However, there are also secondary value from that, collecting that data, and to be able to leverage our privacy innovation that Wales as well won European awards for, to use that data in an appropriate fashion, such as looking at the demand and supply within health boards, trying to plan better services, enable prevention. There's huge value in prevention, and currently we don't have the data to be able to actually employ that capability, if you like. So it all starts, and then also the fourth one is research and innovation. How do we adopt truly transformative technologies such as AI and integrate that into our healthcare system? The National Data Repository is the foundation for all of that. The standards that we use for the data is the foundation for all of that. So where we need to sort of shift to, if you like, is to get the data into the National Data Repository. It should be a priority for Wales, as well as raising the data standards. Once we get the data into the National Data Repository, we can then actually leverage it and extract the value that we've been talking about. Okay, David, I don't know if you want to say something else.
Yeah, just if I may. So other sectors have gone before us in terms of creating this large data platform. As Matt said, it's there primarily to support clinicians, but there are huge opportunities to use analytics to provide insight and drive value for the system. So the sooner we get to that point where we can exploit it, the better.
Okay, thank you, Ruth. Thanks everybody for the time in the discussion today. In terms of themes coming out of the discussion, there are three things that I'd like to take on to emphasise. Firstly, the discussion that we had on the app and getting that to a place where there's universal experience for every patient in Wales, regardless of where they are, and that it is, delivered in a way which enables us to be clear with them about the value of the app. Secondly, we talked a fair amount about aspects of programme management. I want us to focus on more proactive ownership of some of the perhaps predictable challenges, including in relation to implementation risk, which come from managing the range of programmes that you are doing and getting that to a stronger place. And then thirdly, we spent a little time at the end discussing the importance of getting the staffing model right, clearly making sure that skills and capability is there at all levels in the organisation, from leadership to the shop floor, so to speak. And I'll be keen to see how the model adapts to reflect the changing model that you described today. But thank you all very much for the discussion. Do you have anything?
Yeah.